community frontline health workers or people around this table to get involved in this kind of work out of either passion, could be faith-based, could be agency-based energy, and those are essential. That's essential, and I think Anita made that point very, very well a few minutes ago. But one of the things that and this is just my own bias and my own experience, one of the things that often is missing from the equation, we have the tools, we have the right people, the leadership, the agency, the motivations, but we don't always have the right question or the right data. So we can waste a lot of time and energy and agency on problems and issues that may not matter very much. Or we may waste a lot of that time and effort on initiatives and programs that aren't achieving our goals. So it's really one of my biggest lessons learned from the beginning is that the first thing that's important, whether it's ECHO or whether it's one of my programs or colleagues, is to have to define the problem first that you want to fix and define it clearly. It's not enough to say we want to empower, we want to leverage ECHO or some other program to empower communities to improve. That's the motivation for us, but it's not an outcome. And I've seen so many programs, NGO, really incredibly dedicated groups of NGOs, put a lot of time and effort, but not know whether or not they're having the impact that they really mean to have or intend to have. And it's a different skill set, being able to measure data. So one of the things that we've learned over the years, and you've heard a lot of other examples, is that the technology opportunities are incredible. We have our own mobile health platform developed in Uganda, now being used in India, collecting all kinds of data, telemedicine, providing education through videos for community health workers all over the world, including India. All of that is wonderful technology, but they're just tools. Tools, whether they be tools to build up and train people with information or knowledge, or tools that are fancy bells and whistles and attached to the internet. Those are all tools which we need to be more efficient in our ultimate goal, which is to make a change that matters. And so I think one of the most critical challenges for any program, including ECHO, particularly the size of your program, is to decide what it is you want to fix. And you can't fix everything, at least not right away. So that's where working with, and the other component of this, which has been emphasized many times, it's not us that define that. It's not enough for us to say, okay, anemia is a problem, we think it's important, this is how you measure it, and this is the intervention, and this is how you measure its impact on anemia. It has to be that understanding, that direction has to come from the community stakeholders. So they all have to be they are the ones that have to drive and understand why we're doing what we're doing, why we're measuring what we're measuring, why we're using one tool versus another, why we're using this smartphone versus that. It all has to matter in a way that's meaningful to the communities we work in. And this is not unique to India, of course. This is a general principle. And but I think the only other thing I would add, as I was thinking about this, that's I think an important new opportunity, and I was intrigued by your talk as well about this. The tools are there. I mean, the tools are coming. The batteries are going to get cheaper and safer. The bandwidth is going to come. I mean, it's already there. We already have all these incredible innovations. Their point of care, I can't tell you, we're working on point of care testing. In a few years, you're going to be using finger pricks for a fraction of what we're spending now to get digital readouts of lab on a chip. They're going to link to your software and guide your community health workers to diagnose all these diseases. There's all kinds of additional innovation coming in to leverage this incredible technology. But one of the things, and this perhaps is back to, kind of circling back to Anita's point, is one thing we haven't leveraged successfully in health is social networks. So part of what I think is an opportunity is not only to do innovative agency-based training, but figure out how to further empower and leverage the people we train through social networks. Social networking is changing political situations all over the world. We haven't leveraged it for health. And a related and final point is that, and this is really a burden on us, and I blame us as researchers in particular, it's not enough to collect data that matters. It's not enough to define the metrics that matter. It's not enough to give the training that matters. But we have to give the information back to the communities about what we find. That's really important. We tend to use these gadgets to collect a lot of data. We analyze it. We talk about it in rooms like this, but we don't give it back to the stakeholders, the leaders, the women themselves in ways that matter to them. And what would matter to them? Well, they'll tell you. They'll tell you what would matter to them. What kind of data would they want to have? Why do they want it? Would it help them become better respected in the community if they could if they could show the community leaders that children are living longer and fewer women are dying of childbirth complications? We might know about it and publish it in some big journal somewhere, but what impact would that information have in a way that matters for those same community health workers? If they're running out of, if they're finding that malaria rates are going up and we're collecting the data and we feed it back to them and they find it's because the government's not delivering bed nets, would the social networks then provide an opportunity to provide additional empowerment for them to demand those bed nets or demand the medicines or vaccines that they need? We really have not begun to leverage the opportunity that we have, and I think we can on not just the social networking, but feeding that information back to the communities we work with in ways that matter to them, in ways that make sense to them. So anyway, I think without going into a lot of details, if you're interested, I put a few things out here. We've got lots of projects, tables and tables of projects in India. So you don't have to go through, I'm not going to go through the details. If you're interested in any details, happy to talk later. But I think this is an exciting opportunity for many reasons, I think, particularly because of the tremendous grassroots infrastructure that ECHO has built. Particularly because of the passion, the agency that's in this room, and perhaps outside of this room as well. But I think it's all about, as we said over and over again, the communities, and I'll just emphasize measuring metrics that matter to the community and giving them feedback about whether those are being met. So thank you very much for coming to us.
So we do have a couple of minutes for any questions.
Well, one thing I commend on your sitting here in the infectious diseases center. I was getting ready for a very different talk from you. I was like, okay, malaria, HIV.
I can give you that talk next year.
But
come back anytime for that.
No, actually, thank you very much. I think you really hit on what we are missing, and that is the human and the social and aspect of medicine. And I really appreciate that, and thank you for, I'm actually excited to be here and listening to you for, bringing that up. So it gives me a new perspective on the whole medical field now. So they do look at the human.
Well, as my behavioral scientist friends will tell me, everything in medicine is behavioral.
That's right.
Yeah.
And we heard about everything in IT is behavioral, right?
Yeah. But we lose that. We get out in the real world.
Yeah. Just wanted to maybe share an anecdote or two that echoes some of the point that you raised, which is the involvement of social networks and the involvement of the grassroots people who are the end users in kind of informing whoever is running that system. So when we started this telemedicine program, and it was initially our field partner, there was a significant amount of a top-down approach, where very well-meaning though, but the health workers, once we started talking to them, once we came to the project, we of course believe in design thinking and all that, so empowered them a little bit. So that's the critical. They didn't feel empowered that these big hotshot doctors from the city and big business people are setting up these clinics and we are employees. So the ability to speak up and to share kind of what they felt was where the biggest challenges in the clinic, like just reshaped our thinking. So they actually, we went in with the hypothesis that, getting familiar with a tablet would be a challenge. It absolutely was not. Everybody, the younger ones have smartphones. They Facebooked all of my graduate students within like the first 12 hours. So they're still like alumni 2 years out are still Facebooking with these women in Sundarbans who don't have electricity, but they managed to. They started their own WhatsApp group. There was a big lag on like bug fixes from the ground. So they suggested, why don't we start a WhatsApp group? And add your graduate students on the WhatsApp group. So every day we can give you bug fixes from the clinic and you guys can work on it on the server side. So a lot of the things that evolved happened because exactly of these issues, the social networks and empowering the stakeholders to kind of be a participator and participatory and be a co-creator in this process. So I appreciate those points very much.
Well, you can really see it in the three of you, and it's funny how you all sat together at the techno group. But you can see it in each one of your discussions of how you considered the end user and you worked with the end user. You lived in a village and you actually did usability tests with the front healthline workers, and your device, is working with people within India. So, she did a great job. Mo putting this email together.
Let me just throw out one other anecdote, and I shouldn't do this because it's against my principles when I just talked about the importance of data. The plural of anecdote is anecdotes, not data. But I was in Gujarat some years ago, and I was asked to talk about how to leverage IT technology for health at a conference. And at one of the breaks, a retired IT entrepreneur from Gujarat came up to me and told me this incredible story. I haven't been able to follow up on it, but it illustrated for me how we cannot separate incentives and empowerment and value from our health goals. And it went like this. So when Prime Minister Modi was the chief minister of the state, many of you remember that he invested a lot in IT infrastructure and put wireless capability basically throughout the entire state. At a time where there wasn't running water, there wasn't electricity, but there was Wi-Fi connections throughout the entire state. And a lot of people said, "This is not. I mean, what are you doing? There's no teachers in these villages, and you're putting Wi-Fi." Well, this guy, was part of the IT business, and when he retired, got some of his friends together, and they said, "What we should really do is set up a microloan program for women." And they did that, and they set up a microloan program, as I remember, that reached out to about 600 women throughout in villages throughout Gujarat. And what they did is they got a loan. The women took a loan and were trained for 3 months on how to use the software in these computers to deliver very specific services to the village using solar powered. They basically set up cyber cafes in these villages, and what they did was provide things like Gujarati language training to the kids because the school children would show up. They helped arrange marriages by email communications. They were helping the farmers to bulk buy supplies and understand the weather patterns so they could plant and seed at the right. And they collected, they created a cottage industry, and they were able to pay off these loans from these small services that they set up in villages all over Gujarat. And it was a very successful program. It was growing and growing and growing. And then he said, I got this idea, and I talked to an ophthalmologist friend of mine in the capital. No, it's not the capital. Ahmedabad, it's not. No. So it was Ahmedabad. So he said, I talked to this ophthalmologist friend of mine in Ahmedabad who said, look, he said, could you give me an hour of your time every month to screen the eyes of children in villages in the state? He said, sure. So what they did is send out to all these villages a small little video camera, very cheap, that they attached, a little bit of software to do essentially a telemedicine program. And so pretty soon what this guy would do is he'd get on his computer once a month and they would systematically screen the eyes of all the children in all these villages. They would be in, these 3 villages for this day, and then next month the next. And the kids would line up, and they were getting, the same women who were running the cyber cafes had these kids line up, and this kid's eye's fine, next, fine. Oh, that kid's eye's a little red. Here, put these drops in the kid's eye. Oh, that kid really needs to see, needs corrective surgery rarely. Let's make an appointment for having to come out to see me, a month from now. And they systematically screen all the eyes of all the kids in the program. I would then talk to them about, well, why don't you start screening all the pregnant women using the same system? That's not the point. The point was, to me, that the light bulb in my head is, we often start our programs like this with our focus on health. And we don't think about the sustainability and the incentives that are necessary for these programs. What was unique and really fascinating to me is they started with a business model that worked. They started with an incentive system that gave these women, through their whatever agency was provided by having access to resources, an opportunity to make a living.
Right.
First, and then put health on top of that. And it seems to me we could be thinking more creative. There are people thinking about this, for instance, using conditional cash transfers and incentive-based training, and I would challenge you to think about this more in India, for one, not only because I think it's interesting and it could work if it's done well, but healthcare in India, and I think we saw a slide about this, has been, in my 37 years in India, it's been transformed completely. When I first went to rural Bihar, there were no doctors at all, except for some traditional healers, perhaps. Now you go even to those same villages, you're going to find private practitioners, not good ones necessarily, but they didn't even exist, even bad ones didn't exist, 35 years ago. The government is not replaced, the Indian economy has grown and the system has grown such that the private sector has come in where the public sector didn't exist. And it's now, I can tell you that it's not the same now, and I work in Uganda and Ethiopia. Ethiopia and Uganda and their villages are where India was 35 years ago in this regard. India has created a private healthcare industry. And as we've heard, the quality of those services in rural communities are not great, but the people are there. The community health workers are there. The industry is there. We need to leverage that instead of replacing it with a public sector. I really don't see the point in trying to push that aside and create a public sector option when it's the train has left that station, even in the very rural communities. So the key is to figure out how to leverage that, and I think that's where finding ways to incentivize payment for community health workers who do a particularly good job in saving babies' lives or getting vaccines out or correcting anemia would go a long way. And figuring out how to integrate that into the private sector in rural India would be something to think about.
Excellent. Please, guys, give that Are you having fun so far?
Yeah.
Learning lots of good stuff? So how about we take a moment to share that with the world? Okay? So I'm going to get us started. There's this application called Facebook. You've heard of it before? Yes? Yeah. There's a feature in it called Facebook Live. And what you'll find is, as far as trends go, it's picking up like a disease that's out to kill the universe, right? It's becoming very, very popular very quickly, and it's extremely easy to use. So while you're doing the good work in the world, it's not good enough for you to just do the work. You also have to tell people about it. And if you're going to tell people about it, do you want to tell them this way? Hi, I did this really awesome thing. Or do you want to be excited about it so others get excited about it, right? So because you have a choice in how you communicate with others, and that is going to directly affect how that communication is received. So what I'm going to do is do a quick introduction on Facebook Live. Then I'm going to turn the camera around. And when I turn the camera around, and you'll know because I will turn the camera around. Okay, that would be a visual on the camera. What I'd like you to do is be super excited and scream like you're actually excited about what we're out to do in the world. Can you do that?
We are, in fact.
And let's be contagious in the world in a positive way. Let's take that positive psychology and pay it forward right now. So I already have my message prepped, and please do that ahead of time, right? What is it that you're going to post with your hashtags ready to go? So hashtag Echo, hashtag Earthopia, hashtag Johns Hopkins to say thanks, and Smart Village. And now I'm going to go live. And also make sure your camera's clean, right? You don't have a smudgy, yucky looking camera. So here we go. 3, 2, 1. I lost connection. Oh, there we go.
And we should say what? The word
Yeah,
silent?
what we
You just,
How do you do it what?
Oh, we're live right now, and I didn't even notice it because the connection is there. Hi, I am Mo Hassan. I'm in Baltimore, Maryland right now at the world famous Johns Hopkins University, and I've been extremely fortunate to MC at a very important this morning, where I've spent all morning with some of the most brilliant minds in education, in medicine, and in village development. And what we're out to do is actually bring together different groups of people that have never worked together before, that have never had conversations before, together to share what it is that they're up to in the world, so we can figure out better ways to work together. And this isn't just some boring, stuffy meeting at a university. In fact, this is one of the most amazing, fun events ever. Making a difference in the world, it does not have to be boring, and it certainly doesn't have to be silly. You can have a great time, make a huge difference, and do it with people you love. And I can tell you right now, there's lots of love present in this room, and I am honored to be with all of you today. So thank you for being here. Perfect. So while I'm ending that video, if you'd like to connect with me on social media, my name is Mo, M-O. Last name is Hassan with 1 S. Okay, Mo Hassan, and you can find me through some people. Alrighty, so our upload's going on, and we'll go ahead and post it, and that's done. And how long did that take, minus the explanation?
About a minute, maybe.
About a minute, right? About a minute, and based on our social network, about 5,000 people will see it in the next 24 hours.
Nice.
Right.
So it's an easy way for you to reach out and make a community. Now, can that 5,000 easily turn into 10,000? Yeah, absolutely. Connect with me, friend me, and share the post, and share your own observation about how your day went. Right?
Now, can we get that to Hillary and Donald?
Yes, we can. There's a few more messages we need to share with us, too. So we are a few minutes behind schedule. Are you okay with sparing another half an hour to listen to 2 more brilliant human beings? You okay? You can spare that time? Fabulous. Thank you so much for doing
And
that.
there's food at the end.
And there's food at the end.
Food.
There's food at the end. So
Okay.
thank you. So we're going to go just a little bit longer here. Thank you for your patience with that. Our next speaker, I think he's here. We'll find out in a second. Anurag Shankar.
Yep, that's
Oh,
it.
Oh, that's right.
There he is.
Well, you're
I know
definitely
him.
here. He's already standing ready to go. So this particular gentleman is the senior research scientist at the Department of Nutrition at the School of Public Health at a small school called Harvard. You guys may have heard of it somewhere on the internet or something like that. So he's here to chat with us about global programs to address and enhance child cognition. So please, a huge round of applause for Dr. Anurag Shankar.
And I am the husband of Anita Shankar.
Oh, that's
That's my actual
So that's good. You know, my friends many refer to me as Mr. Jessica. I like my wife Jessica more.
Mr. Anita.
I am Mr. Anita, yes, that's correct. And I just wanted to maybe underscore a couple of things. I think that the thing that Bob was mentioning is really he talked about these issues around really understanding, is there any impact at all, right? Because we'd always like to know, is there impact? Mostly to know ourselves, is something succeeding or not, and how to improve that. And very often we're doing something, we believe there's impact, because we're hearing a lot of people saying this is so exciting, a lot of interesting things are happening. But when you actually measure it, in fact, most of the time when you do an intervention, you do a randomized trial, in fact, there's no impact at all. If you ask the people who are receiving the services or the intervention, if you ask them, do you believe you're getting a benefit from this? What do you think they say?
Yeah.
They say, yeah, we are, definitely, including the ones in the control group. Right? And so it means that really it's the huge responsibility of all of us working together with the communities to really understand, is anything we're doing having any impact at all? We can spend a huge amount of time, years in fact. I just we're working with a colleague, did a very nice project, funded for 10 years or more in the country. More than, I would say, probably maybe $800,000, something like that. And was convinced there was definitely an impact of this. So eventually, he got funding, did a doctoral work on this, went out, did an actual assessment of it. And he found there was zero impact. So, big surprise, but wouldn't you like to know that? Right? Wouldn't you like to know that? Because it means, it doesn't mean your idea is wrong, necessarily. It doesn't mean your intentions aren't good, of course. But maybe there's a way to change it so it really does have impact. If it already does have impact, maybe it can be even more impact. Right? So that's the exciting thing. And I think working together, you know, with people, with communities is extremely important. We all have a lot of great ideas, and sometimes those great ideas actually make a difference. So I'm going to show you a few things about child cognition, some of the stuff that we've done. I want to introduce you first to a platform, what's called Open Smart Register platform, and I'll show you some of the stuff we're doing on social networks as well, and some other devices. How do I, yeah, just, okay. Oh, this is PDF, right, yeah. So the first thing, so this is about this platform called Open Smart Register. Yeah, Open Smart Register platform. And what this is called, yeah, OpenSRP. This is a platform we developed. There's about 8 of us that created this platform. It's open source. It's open source software. You can go to smartregister.org. You can go to GitHub and you can look up OpenSRP and you'll find a ton of code there. You can download this stuff and start working on it immediately. It's completely open source. Every night, all the updates on the code is posted there, and anyone can download it and start working on it. The original goal of this was to, in fact, take the frontline workers in lots of countries, of governments or school teachers or whoever. They often have a piece of paper that they write down all their clients on, and they're tracking who came to school, who came for services, who I saw at the government outreach clinic, whatever it is, right? And this is all on paper. So the ability to use this information in an intelligent way is kind of difficult because it's hard to do any sort of analytics, identify gaps or what's actually happening there. So the goal was to create some platform that made it particularly easy to catalyze open source software development communities in countries to port those registers onto a platform. And then use that to do analytics and smart reminders, so you would have a tablet or a phone for the service provider. So, and just to go back one, I just want to mention one more thing, which is that this is actually built on, in one sense, Open MRS. So, Open MRS was intended originally to be an open source platform for tracking clinical health care and concepts. It didn't have what was called concepts or definitions in it related to community care. So in this process, we've added about 300 to 400 concepts into OpenMRS that allow you to actually track community-based care through OpenMRS. And so that means all the advantages of OpenMRS, which get pushed up into government health information systems and so forth, that's actually available now. So the goal of OpenSRP was actually to create a data ecosystem from the clinic to the community, essentially, to the household. That space, which was an empty data space, essentially. Okay, so next slide. So this is just the basic appearance. This is the build from Indonesia. It's currently being deployed in 3 countries. Deployed and developed in 3 countries, Pakistan, Indonesia, and Bangladesh, and a population base of around, I would say, 3 million people. And so this is the, here's the books or the paper registers sort of in this e-form that appears on the initial screen. Next slide. And we go through the workers locally, asking them how do they want stuff to appear on the screen initially, and we develop what this information is, what they would like to have. Each of the clients there that they're managing has a picture. We've now added to this the facial recognition feature, so you can actually come up to someone and click on them and their information appears there. So you know if they're already in the database or what you've done, and that exists on the tablet itself. So it doesn't have to be connected. All this works offline also. Whenever you get the opportunity, you can of course synchronize to the the server. So next slide. So these are just some of the features. I think these are, common things about how you track things. Next slide. There's these risk flags that you can put in there. So if a woman is at higher risk for something, or if a child is at higher risk for something like missing days of school or whatever it is, that gets flagged, and then that gets highlighted for the particular person, either the teacher or the antenatal care worker or whoever it is, saying, when you see this child, please pay attention to this. Next slide. So this is just showing examples. So this is for immunization, vaccine scheduling. Are they overdue or not? Just over examples of that. Next. So it's built on very simple open source technology. So many of you may have used this, XLS forms. Who's used XLS forms? Some of you have, yeah. So it's really easy. You can literally create a form and deploy it and have hundreds of people using it in probably, I would say, less than 5 minutes. Right? You just type up the form, put it in there, upload it, you download it, and you get this little app, and then you go to Google Play, people can download it, and boom, you're all set. So this is essentially based on that as far as the data input is concerned. And then the local open source community, which we usually try to catalyze in each country of around three people. And essentially these are Java, people have some expertise or experience in Java programming, because then they go through and they adapt this to the local forms, the layout of that. So it takes, some effort to do that. But there's a lot of access to the open source code, and they can go in and change things and so forth. So pretty quickly, once you get proficient, you can create one register in probably a day or two. And we've currently started doing this in India with Anganwadi workers and ASHA workers, and also A&Ms.
So you're working with ASHA on this?
Yeah, there's a separate project we had in urban slums called Unshol, where we're currently developing this for ASHA workers. But we've done most of the work related to A&Ms and started porting it to Anganwadi workers. Because Anganwadi workers have this huge amount of registers, it's absurd, so I think it's the biggest benefit for them also. Next slide. So these are just the basic forms powered off in Cato forms on the back end. The information on the register, they just enter it here. It's pretty simple. Next slide. So I talked about the risk profiling. Next slide. So this is one of the things that we do. We work with whoever the supervisors are, either at the community level or at the government level, and we ask them, this is from Indonesia, we ask them, how do you want your reporting to look like, and how do you access it? So the supervisor, it's a very simple thing. They just look at it. What are the indicators? What's the percent coverage of services anyone is actually receiving? And what's interesting about this is we're talking about, I think, feedback later, what people want. In most countries, I think, probably India included, is that, well, let me just start by saying, I think the biggest barrier to adaptation of digital technology is not, I would agree with this statement, it's not the technology itself. It's actually the social change created by that. Because all of a sudden, we have this situation where if I'm the worker, she's my supervisor, right? And I'm doing my work, but maybe not as good as I could be or should be. Maybe I have various problems doing that. So I only have to negotiate with her to say that, hey, okay, fine, you're not doing great, try to improve. Next month I improved a little bit, not as much. Next month, oh, I was off, I got sick, whatever it is. But I only have to build that relationship with her, essentially. Okay. Now all of a sudden, hundreds of people are seeing my work every day in real time. Why on earth would I ever agree to that? Right? So so instead I'd be like, I can't turn on my tablet. It's not working. It's crashing. It fell in the water. So that's what's going to happen. Not because I'm, a bad person or evil or I don't want to do the work, but it's because this complex thing has happened now from a social standpoint. Then how do I really work in this environment? Now I'm accountable for a huge amount of work that in principle I was supposed to do from the time I was hired, but I didn't. But I got paid every month for doing half of what I should have been doing, right? So there's actually been a tacit agreement that I'm fulfilling my contract because I got paid and no one told me I didn't do a good job, right? So there's this whole social issue around that. So they would come up with these indicators for their work performance locally. So we would say, okay, just tell us what you think you're accountable for. So we would program it, the back end, like that. Right? Some of them wanted to classify visits in the third trimester as first trimester visits and so forth. So we call these things informal indicators. So we say, okay, great, let's put these informal indicators. So now it bootstraps them into saying, right, and so if you have a local development team, they can come up with these indicators, whatever they want. So Next slide. This generates a report for the local officers. Next slide. Let me skip forward. Next slide. So you can put multimedia on and so forth. Of course, work reminders. Let me go to this next slide here. This Sophia. Okay. So Sophia, what we decided to, because social media and the social aspects of early childhood development were so important, we thought, is there a way for us to actually track what parents are doing, how they're interacting with their children, and use that in a live way to provide advice for other parents, right? So Facebook, somehow, I'm not sure why they made this decision about 9 months ago, they decided to de-link the chat messenger service from Facebook. They created the API so you could interact with that back-end chat messenger on Facebook through your own information server, right? So we created all these chatbots, one of which was Sophia, and we chose Sophia because Sophia turned out was the name most common to different cultures, right? And so someone should have actually done some research on this. So you can go to Facebook. There's a page there called Sophia ECD. You can become a friend. I was never on Facebook until this. So you can become a friend of Sophia's, and she starts asking you questions. You can see, you can track. This is just the back end. We can go to the next thing. And she starts asking you questions about your child. How old is your child? Can your child sit on their own? Can they walk, and so forth? And what we do is we use this information to ask questions about the parents, about how your child is doing, and then we say, who was the population of parents and kids 6 months ago that was just like you? And then amongst them, over the following 6 months up to now, who advanced the most in their early childhood development, and what did those parents do? And then we make those suggestions back to you, right? So you keep doing this sort of AI data mining. It's a machine learning, it's a complete empirical platform. And you create this bot technology, this smart bot technology, for a variety of purposes, whether it's diagnostics of a condition, because whether or not you're at risk of having malaria or tuberculosis, that decision tree, that initial medical decision tree is very useful, but it's affected and refined locally by whatever local other risk factors that you might not necessarily be aware of. So now you are able to capture other information, right, and use that for predictive value and refine what these questions are being asked through this artificial intelligence backend. And Sophia is a customized bot for each person who joins. There's a back-end version of Sophia for each person, right, because you have personalized it. You're talking, it's like a person that you're talking to. Next. Next. So the other thing we're able to do is share information on this platform across multiple frontline workers, right? So if there's multiple workers, one's collecting information on vaccination, one's collecting information on nutrition, they're able to share this information because often there's redundancy in actual data collection. And so this allows us to transform, next slide, from what I call this provider-centered network, where essentially there's multiple frontline workers that people are going to, and each with their own information base, seeing this person, we can transform that to the next slide, to this what we call the client-centered approach, which these workers now, these multiple ones, the education worker, the clinic worker, the community health worker, they're all sharing information as a team coordinated that what this mother and child or family really needs to have. So this is the first time you could ever do something like this in the history, because on paper-based system, you can't do this. Right, so this is probably one of the biggest revolutions in information management, frontline worker management, I think, in public health in a long time. So let me show you a few other things. I just have a minute left. So one of the things we wanted to do also, next slide, is on the tablet, to think about, you have this tablet, and many tablets have a camera on it, and also some advanced analytics on it, right? So we thought, what can we learn just from analysis of sounds that are recorded and videos that are recorded? Can we get health information out of that? So we started with this process. This is a woman who's in antenatal care, and from a 1 minute video recording, next slide, we're able to actually extract off of that the heart rate. And some of this technology you've probably seen on the web. But this is from her ECG, this is from plethysmography, and there's her heart rate extracted just from a 1 minute video of her. So this matches actually pretty well. Next slide. This is for a child also. You circulate, highlight the regions of interest, and we get off that the heart rate variability, the respiratory rate variability, just from the phone getting some diagnostics. Is this kid frail or not? no connection to anything, just image analysis. Okay? And then, so this is what we've been able to determine so far, that just from a video, we're able to actually pick up information about whether a woman is at risk for gestational diabetes, and we were able to create this new composite measure of heart rate variability, enabled us to look at whether she's at risk for hypertension also. So just from the video itself. Let me skip over these couple of slides. Let me skip down to this one here. So then we thought, well, there's some cheap attachments you can buy at the hardware store now that let you get infrared images of people. They cost like about 150 bucks. So we thought, well, maybe that might be useful, right? So this is the same thermal image of that woman who I just, you see. And so when you're breathing, of course, you exhale. So this part of your nose heats up. So if you go to the next slide, we can easily get her respiratory rate off of that, right? That's like very simple. So that's a regular respiratory rate, that's a respiratory rate there. And then we started exploring some of these issues. You have these hot spots on your face. So the question is, if you're sick of certain different things, is the co-regulation of the hot spots on your face somehow changed? Right? So this is the hot part of your face. Hottest part is right here, actually. You can see these different hot regions. This is captured by actually a $5,000 thermal camera. And next slide here. This is the side image contour thermal heat image of that particular individual. So this is her forehead here, either her eyebrow, the cold zone on your face is right here. This is her hot zone. Here's her center part of her eyes here. This is probably how like a pit viper or a snake that sees in a thermal image, that's what a human face looks like. If you're lying down sleeping and that thing's crawling up on you. So the idea is to see now from this cheap camera, can we in fact get the same type of information from the $5,000 camera? So more or less you can. Right? So now what we're doing is going through and looking at the fluctuations of these, the correlation between them. Are these predictive of certain conditions? Right? So just from the very simple device that you have. So the whole goal, the framework behind most of the work that we're doing is related to what's the ecosystem of information, how do you manage that information, and how do you use that information in real time, mined from everyone to help each other by linking it into a social network also. And all these regulatory things, these diagnostics are also essentially based on not one measure of heart rate or respiratory rate, but trying to think the measure of health is ability to adapt. So we measure the co-regulation of different physiological systems of the body to assess health. Because that's something you can do just on a device. So that's, I'm going to end there.
Hold your questions
Sure.
till our break if you
Yeah,
don't
thank
mind.
you. Sorry about overtime.
Thank you. No, that was
that was
fabulous
amazing.
and mind-blowing and all sorts of good things at the same time. Whew, that was awesome. Thank you. I take it at your household you're not watching Keeping Up with the Kardashians.
No.
That's not like what you're telling us to do. Yes,
You're not watching that? I thought you were watching that.
I'm sure she'd be great for the women's.
Anyway, so we are on to our final speaker of the day. And
I can vouch for him, it's worth listening to.
yeah, we're listening to. And unfortunately, I apologize. I don't have much on you except you're not Dr. Frank Wang.
So
I assume you're going to be chatting about new technology to detect.
sickle
Sickle
cell
cell-
disease. Yeah, different types of anemia.
Okay, different types of anemia. So please welcome Dr. Amit Bhatt. Amar, okay.
That's okay. And I apologize also. I am here on behalf, well, I'm here in two different capacities. One is, I was talking to Shashi about, being here on behalf of Open Health Systems Laboratory, which a few of you may have heard of. It's founded by Anil Srivastava, who's a friend to many around the world, so I'm not surprised if you already know who he is. And we are a kind of a, what we call a public benefit corporation that is kind of bringing together global health, biomedical research, particularly in cancer, and IT, advances in IT, especially supercomputing, informatics, big data, things like that. And then my other hat today is I'm an advisor to a company called Biomedomics. I provide the information, advice to them about entering the Indian medical device market. But Biomedomics, the CEO, Dr. Frank Wang, who was supposed to be here, he because of our good friend Matthew down in the south. All the flights out of North Carolina, RDU, he's coming from Research Triangle Park, have been canceled, so he wasn't able to come up. So I apologize on his behalf, and to the extent that I can, explain what's happening with biomedomics, the products that are in development that I think will be of interest to this crowd, and the questions you may have, well, I'll do my best there. Before I get into biomedomics, just a couple more words on OHSL. I just wanted to talk about, given the conversation that I've been hearing today, I thought I'd at least share with you one activity that we are now involved in. It's called the Indo-US Cancer Knowledge Alliance. We call it IUCA for short. IUCA is something that's still very much in development. It is trying to bring the power of IBM's Watson for oncology. I don't know if you've heard of Watson, but Watson is this incredible supercomputer. Well, I'll call it a supercomputer, but it's this cloud-based computer that has ingested enormous amounts of medical data, medical publications, et cetera, et cetera. Basically, they've tuned it into the super assistant for physicians in the oncology space. Now, what we're doing is, and we're a partner with IBM on this, what we're doing is taking that as a base and then overlaying it with India-specific data. So a clinician, an oncologist in India would be able to pull up on their little device, on their phone or whatever, not only Watson for oncology, now there's the latest in medical developments, latest clinical trials, latest treatments, et cetera, for a specific cancer, a specific stage of cancer, et cetera, but also what is happening in India at that very moment, whether it's clinical trials, whether it's what's the treatments that are taking place in their country, their state, their locality, their institution, whatever, as well as other information that is relevant to an oncologist as they are seeing a patient. So it's basically real-time information. We're doing this right now. We're collaborating with two hospitals, Tata Memorial Center in Mumbai, and also All India Institute of Medical Sciences, their cancer center. So this is something that is very much in development. Our hope is to kind of spread this throughout all the major hospitals. There's like about 80 or so hospitals in the national cancer grid of India, and over time, hopefully, we'll have it spread to them. We're, as I said, very much in the early stages. We're still kind of pulling together data, but the idea is to make that data available to oncologists, not just, the whole mass data, but the data they need at that point. So I'll stop there and get on to our friends at Biomedomics. Biomedomics is a startup company. As I said, it's based out of Research Triangle Park. It has only a few products already on the market, but most of its funding has come from government NIH grants and SBIRs, if you're familiar with that. Has some patents, and as I said, it's a very small team. But main thing here is that what I'm going to talk about is the three products here: sickle scan test, alpha thal test, and hemoscan. Let's see if this works. Let's point that way, or okay. So I'm not going to go too much in detail on the science. If you like, I can provide the slides, and you can read them at your leisure. But sickle cell disease is a major concern in India. About 50% of the world's sickle cell population patients are in India, with about 45,000 births with sickle cell disease. Most of these are in in hard to reach areas, tribal areas, disadvantaged communities, etc. And we've got the testing that they've done says rates of about 10 to 15%, as you can see here. Now, where I got pulled in is when the government made an announcement that they wanted to screen about 50 million children for sickle cell disease or sickle cell trait, and mainly in the tribal areas. This is coming out of the Ministry of Tribal Affairs, and we thought this would be a great opportunity for this product. I'm not going to go into detail here, but you can see that India has some of the highest burdens for sickle cell disease around the world. new births, out of 25 million births a year in India, we've got a rate of a 0.1%, we're guessing here, but that's just a guess because screening is not that great. I'm not going to go into the genetics of it, but basically sickle cell is a genetic disease. The traits are passed down from parents. You have to have both parents passing it down to you in order to have the disease. Otherwise, you have the trait. And so current testing for sickle cell disease is actually rather burdensome, I'll call it that. You have to have a well-equipped laboratory that can do the genetic testing of this. So this is one system here, is another system here. You can see this is not something that you can find in a rural area, obviously. What happens is that they have to take a blood, if you're doing a camp, let's just say, a screening in a camp in a rural area, in a tribal area, you have to take a blood sample and then take it to the lab, and they will go through two different types of tests. First is a screen, where they basically, it's a fairly simple, fairly inexpensive screen, but it's not confirmatory. Then in order to confirm it, you have to go through one of these systems. And again, as I said, this is something only the more well-equipped labs will have. What Biomedomics has put together is what they call a point-of-care diagnostic. This is it right here, that will allow you in the field to test for sickle cell. All it needs is a little pinprick of blood, 5 microliters. Mix it in with the buffer and put it onto this here, just like a pregnancy test or something like that. And in 5 minutes, it'll show you whether you have the trait or the disease or you're normal. This is light years. Well, light years is not maybe maybe exaggeration, but it is a considerable advance over the current methods in terms of how you can in the field test for sickle cell disease. Sample collection is very easy and should be done as part of newborn screening. It can be done as soon as 24 hours after birth. As you can see, this is they're taking a sample using filter paper from a newborn. Just punch out the sample, drop it in the buffer, and then you can use it to test. And again, I won't go into the details here, but basically the test sensitivity is very, very good, comparable to the lab systems that I was showing you earlier. It shows not only the disease, but the trait, the C trait, and whether it's normal. All right, now, thalassemia, another big problem in India. This is another type of inherited blood disorder. One of the things that is different about thalassemia is that there's 2 different forms, alpha thalassemia and beta thalassemia. Worldwide, you can see this is the incidence of thalassemia. You can see it's heavily in Southeast Asia, Mediterranean countries, and in Africa. This is both alpha and beta, I should mention. Biomedomics has developed 2 different systems. One is for alpha thalassemia, and again, each individual has 4 copies of the gene encoding the alpha globin. The severity of the alpha thalassemia depends on the number of alpha globin genes that are deleted or are non-functional. And again, similar to the sickle cell scan, we have a test that uses just a pinprick of blood to test whether you have alpha thalassemia. Beta thalassemia is a little bit different. Here it could be a cause of, there's more than 200 mutations that can cause beta thalassemia. A large, and you can see some of the, so we have a lot of variations from a genetic perspective of what can cause beta thalassemia. Much harder to detect, obviously. And so the system that they've developed is a little bit more complicated. It's a box, I'll call it, a device where you put it in, but it basically will allow you to know whether you have increased amounts of hemoglobin A2 or hemoglobin field, which indicates whether or not you have beta thalassemia. And then finally, I just want to mention HemoScan. This is a little bit more, this has been around a while, but basically this one helps to, this one I know the least about, to be honest. So, but basically it's also for the treatment of sickle cell, you have to monitor the hemoglobin levels. And this will allow you to do that in a fairly rapid and easy manner, much like measuring your blood glucose. All right. Again, what's good about HemoScan is a quick turnaround, use low resource settings, uses only a finger stick or heel stick amount of blood, low overall cost, and high sensitivity and specificity. But yeah, my biomedonics is focused on different types of blood disorders overall, and committed to kind of developing diagnostic tests that are going to be useful. These are issues that are prevalent not only in India, but also throughout Southeast Asia and Africa. I will say that these products are, for the most part, still they're developed, and they've been approved in Europe and Africa. FDA is still still reviewing them. We don't expect the regulatory approval from FDA until later, first quarter, maybe mid-year 2017. Still about 9 months away. Only after that, I should say, because of India's regulatory laws, only after the US FDA has given its approval will the Indian regulatory system or authority start to look at it. They won't do it in parallel. Now, actually, I'll say this, and as I said, this is where I come in. India's system for medical device regulations, including diagnostics, point-of-care diagnostics, is undergoing rather significant overhaul. There are some draft rules in place that will change it. Interestingly, India does not require clinical trials. I'll call it significant clinical trials of medical devices. They are much more, but they rely on what's happened in other countries. Hence why they require home country approval before they'll look at it. All right, I'll stop there. I'd love to answer questions as such as I can. And yeah.
We'll have a minute or two for any questions for Dr. Bott.
Can you say a little bit about what you mean by low cost?
Sure, I knew that question would come up. So the sickle cell device currently is about $45 a piece for that. This compares to the screening is probably about $2 to $3 right now in India, in rupee terms, $2 to $3. But the second level confirmatory testing can run as high as $50 to $100, depending on it. So $4 to $5 to have confirmed sickle cell disease is a considerable cost savings. And as I said, it's also lower cost because you don't need trained personnel. You just need somebody who can do the stick and put it on the thing. And you don't need to cart it back to the lab for testing, so you don't have to worry about the transportation. You don't have to cart the results back to the person because they can, if they can wait 5 minutes to get the results, and that's important. Now, one thing to consider about that $4 to $5, that is current cost with manufacturing here in the U.S. The idea is that once we are approved in India, we will move manufacturing to India. That'll drop it down to as low as at least $2 to $3 and maybe as low as $1 per test. That would be a considerable savings. The alpha thalassemia, I should mention, alpha thalassemia is not as prevalent in India. It's more in Southeast Asia and Africa. But alpha thalassemia, that test is also $4 to $5 range, and cost can go down again with local manufacturer. By the way, the cost savings are in the transportation costs. Getting, if they're manufactured in the U.S., they have to get to India. That's where $2 to $3 come in. So that's where the savings. And the beta thalassemia test, that's a little bit more expensive. You saw that device. The cassette is about $7 to $8 right now. The reader, the device, is about $2,000 to $3,000. So it's more expensive. And The hemoscan is, I think, in the order of about $100.
Yeah.
I need you to.
Well, just a quick question. So, what is the outcome once they get this information? They also educated on how to treat?
Well, biomedonics is not involved in the counseling
Okay.
or the treatment side. However, that's the idea is that it would be part of such a thing. I mean, basically, you're out in the field. You have a mom comes in with a newborn. They test it. Okay, it looks like it's got sickle cell disease. They can tell you right there on the spot what you need to do next. That's the idea anyway. And there are treatments that can be done. I think there's that are, that can, you're more beneficial to start earlier in life.
Okay.
However, biomedonics is not involved in any of that portion of it. Yeah.
Last one. Is that state any, in the map, in the graph?
It's Maharashtra.
Is that state more prone to?
This is Maharashtra?
Correct.
Yeah, no, not necessarily. I mean, it's actually also in this area as well.
Right.
In some of the eastern states.
Okay.
Don't worry, it's not there in Rajasthan. Don't worry.
The Ministry of Tribal Affairs has identified about 10 states that they really want to focus on.
Right.
Do you think sickle cell anemia is lesser than, you think, what I think is thalassemia is more in number than sickle cell, right, in India?
I wonder because I haven't seen that many, what do you call it, too many epidemiology studies to show definitively, but obviously it's been a problem.
This is true all over the world where there's sickle cell. These children don't do well, so they die very, very young, long before they're diagnosed. Specifically, and in those communities, nobody's really documenting the cause of death. So they're really not good data to show the prevalence. And hopefully tests like this, if they're more widely used, will give you better data on how common these things are.
Yeah. Yeah.
Is there any initiative to use this data for the future when it comes to people getting together and reproducing children? Because I know with sickle cell, it's...
You mean genetic counseling?
Yes.
Yeah, that is some of the ideas is behind it. I mean, again, I want to just make it clear, biomedonics is making the device. We're not doing the social programming that should go along with it. But yes, genetics counseling is important. Before a couple gets married, if they had the test done, they will know whether either one of them or both of them are carriers, and more likely to produce a child who has the disease or at least a trait.
Excellent. We'll take more questions from you.
Okay.
Great. Thank you so much. Big round of applause, please.
I actually have to leave, but I was going to say, if you want more information on the cancer activity that I was referring to or any other OHSL, our website is ohsl.us.
Okay, perfect. Well, before you leave, can someone pull out a camera?
Oh.
We have a certificate of acknowledgement for you.
Okay.
So let's get a photo. That's a wasted opportunity. Editor Dr. Willinger, will you come up for a moment?
And Sudhir?
We'll come and just take a quick photo here. Can't mind you leaving without a social media opportunity.
I'm behind the scenes.
Yeah, I'll still get up there. All right, that's a slow walk. Come on.
All right.
Thank you. Thank you very much.
Great to see you.
Good to see you.
Been a long time.
Yes.
Oh, nice to see more of you.
Yeah, exactly,
Assembly.
exactly. Oh, wait, I need.
Oh, yeah.